This meeting is now being recorded. Good day and welcome to Mental Health in Transition, Panel 3, Mental Health as Public Health. Thank you for joining, and please welcome Michael Bird from Trinity Church Wall Street.
Welcome everyone, and thank you for joining us today for the third panel in the Mental Health and Transition series, presented by Fountainhouse in partnership with Trinity Church Wall Street. I'm Father Michael Bird, the vicar of Trinity Church. Social justice is one of the core values at Trinity and is foundational to our mission to build neighborhoods, generations of faithful leadership, and financial capacity. Our work, in partnership with others, aims to break the cycles of mass incarceration, mass homelessness, and housing instability in New York City. Through our direct outreach work, our advocacy, speaking in the pulpit and in public, and philanthropy, we are actively seeking to transform our neighborhood by changing systems, organizational structures, and attitudes for lasting change. We know that our engagement with these issues must include advocacy for those people living with serious mental illness and for the most vulnerable members of our society. And we are truly proud to be partnering with Fountainhouse in this work. Let's begin with a prayer. God of all creation, your dream has always been for us to be one community and family, ruled by love, justice, freedom, and peace. Keep us mindful of the most vulnerable and help us to walk alongside them. Time and again, you have called us to live in the fullness of your love and reach out in loving kindness to the disinherited, those that our society has left behind or ignored, the least, the last, and the lost. We ask for the endurance, the vision, the courage, and conviction to build communities where no one goes wanting, where no one is outside the compassionate embrace of our vocation to love and serve. And we ask you to help us see and know that we are all in this together, that we are mutually in need of each other's encouragement and grace, and that your Spirit will sustain us in this work. All this we ask in the name of our God who loves us all and knows us each by name. Amen. It is now my pleasure to welcome Dr. Ashwin Vassen, President and CEO of Fountainhouse.
Thank you so much, Father Bird. Good morning, everyone. I'm Dr. Ashwin Vassen, President and CEO of Fountainhouse. For those of you who are new here, Fountainhouse is a national mental health nonprofit fighting to improve health, increase opportunity, and to end social and economic isolation for people living with serious mental illness. Over 70 years ago, started here in New York City, we originated the Clubhouse model, a model of social infrastructure based on principles of social work and human-centered design, created to build community, to break isolation, and to improve health and opportunity for people who are uniquely marginalized and isolated and who live with health conditions that are isolating in their own right. Our work has been replicated more than 300 times around the US and around the globe, including 14 affiliates right here across the 5 boroughs. And we're working to build this into a national leader in transforming mental health systems for people with serious mental illness and transforming our public health and policy landscape to meet their needs. Thanks so much for joining us for the third and final panel in our series, Mental Health in Transition, presented by Fountainhouse in partnership with Trinity Church Wall Street. I especially want to thank you for joining us on this chilly Monday morning, hopefully from someplace warm, and I'm thankful to technology for making this all possible. For those of you who joined us for panels 1 and 2, thank you for continuing with us as we explore these pressing issues and push for new solutions in a post-pandemic New York City. For those of you who missed our first 2 panels, Reinventing Public Safety and Rethinking Housing, video recordings of these events can be accessed at fountainhouse.org/MHIT. To start, on behalf of the entire Fountainhouse community, I want to congratulate the new mayor-elect of New York City, Eric Adams. For months on the campaign trail, Mr. Adams has been a vocal proponent of mental health, recognizing that our current system is not only incredibly wasteful and ineffective, but fails to protect the basic human dignity of people in need. He has also on numerous occasions pointed to Fountainhouse as a solution grounded in public health and innovation and a partner for his new administration. We welcome this opportunity to reshape the way we support those living with mental illness in our city. Today's topic is mental health as public health. It's a subject I'm especially proud to be diving into as a participant on today's panel. Public health is my first professional love. It's about saving lives at scale, affecting and improving the health of entire populations, not just individuals. It represents the intersection of science and society. And I think we've seen with the COVID-19 pandemic how sometimes science alone is not enough. We have to root solutions in people's experiences, in the experiences of our communities, especially those disproportionately impacted. And now we're in the midst of a mental health crisis, one that predated COVID, but certainly has been exacerbated, and that is going to require a population and a public health approach rooted in social need and in healthcare if we are to save lives going forward, not just for this generation, but for our children. When I joined Fountainhouse as president and CEO in late 2019, I could have never predicted that my first year at the helm would draw so significantly upon my prior experience and training as a public health practitioner and an epidemiologist. As we were forced to close our physical space for the first time in 73 years, we looked forward, as always, in partnership with our members, and we transitioned our work to a virtual setting, like many of you. And we found that creating community can be done in both traditional and in innovative ways. And today I'm very happy to share that our physical locations all across the city are open up again, and we're operating hybrid programs as well, pushing us into a digital future where we meet people of all stripes, wherever they are, however they are, with whatever they need. Fountainhouse is rooted in innovation and in refusing to accept the status quo. We've witnessed an acute need and in turn have expanded our programming during the pandemic to create on-ramps, a collection of outreach programs supporting people who are justice involved and are experiencing homelessness and substance use disorders, and piloting solutions to meet them where they are with dignity, humanity, and respect in order to build relationships and trust that will ultimately bring them into housing and into programming such as Fountainhouse clubhouses and care management services. But we're also fighting upstream, advocating for changes that will prevent people with mental illness from becoming intertwined with our justice system or experiencing homelessness or economic security in the first place. And we're intervening even earlier with young people who are experiencing trouble in school, in higher education, fundamentally working over the last 6 years with our college reentry program to redirect trajectories, to prevent people from developing the most serious forms of mental illness and to prevent them from experiencing the social and economic isolation that is a hallmark of these conditions. So today I'm really pleased that Sikan Akpan, Health and Science Editor for WNYC, is moderating our panel. Sikan joined WNYC early this year and previously was at National Geographic, where he worked as the science editor, overseeing COVID-19 coverage, in addition to other types of science, health, and technology news. And I want to thank my friends and fellow panelists today, Jennifer Jones-Austin and Dr. Amanda Parsons, for joining me to discuss our work and the solutions we hope our incoming Adams administration will invest in. We know there's a lot of work to do, and no one can do this alone. So we're grateful to all of the panelists in our series and to all of our audience members for making these issues a priority. Take it away, Sikan.
Thank you, Dr. Vasan. And I want to thank Trinity Church and Fountainhouse for asking me to moderate what should be a fascinating panel on mental health and public health. I want to remind people in the audience that we will be taking questions. And so actually, if you see my eyes dart to the left, which they will do from time to time, that's me looking at our internal chat for those questions. I think public health, both in the city and nationally, had plenty of stress points prior to the pandemic, but COVID-19 really ripped open those issues in a way many of us couldn't have imagined. In the mental health arena, we saw the healthcare community rise to the challenge in many places, when it came to things like telehealth and other resources that people would need to live in a socially distanced world. But we've also seen great setbacks, such as the big spike in drug overdoses this year and the interruption of plans to install safe injection sites in the city and both in the state. At WNYC, I think our newsroom is dedicated to exploring what these fissures are really going to mean on a day-to-day basis as we transition, hopefully, into a world with less COVID. But I think that's also enough for me. And so I want to introduce our panel. As we just heard, Dr. Ashwin Vasan is the president and CEO of Fountainhouse, a national nonprofit fighting to improve health, increase opportunity, and reduce social and economic isolation for people with serious mental health. Since his appointment in 2019, Dr. Vasan has grown Fountainhouse from a direct service provider in New York City to a national leader in mental health. Under his leadership, Fountainhouse's work has advanced at the intersection of health, mental illness, homelessness, criminal justice, and social welfare for marginalized communities by centering the voices of people with lived experience. Jennifer Jones Austin has devoted her career to fighting for the equal opportunity for all, with a keen focus on dismantling systemic barriers for persons of color, women, and children. A fourth-generation leader of faith and social justice, she is the CEO and executive director of FPWA, an anti-poverty policy and advocacy nonprofit with 170 member organizations. Its work is centered on economic opportunity and upward mobility. She's also a radio host, awesome, an author, a public speaker, and sits on the board of many organizations involved with social justice and the law. And Dr. Amanda Parsons amassed extensive experience in physician leadership, population health management, and health strategies, as well as management consulting before joining Metro Plus Health Plan as Deputy Chief Medical Officer, where she oversees care management. So we're talking about Medicaid and Medicare, managed long-term care, children's special services, and MHP's social determinants of health programs. And Amanda, I want to start with you. As someone who has worked in numerous health systems, both public and private, what are some of the biggest challenges you see in terms of bringing mental health into public health, namely in this COVID world, hopefully post-COVID world that we're moving into?
Well, first, I just want to say good morning, everyone, and thanks so much for having me. It's a delight to be able to represent Metro Plus at today's panel, and I certainly have a lot of admiration for the work of Dr. Vasan and Jennifer Jones Austin, and it's a real pleasure to be here with you today. I would say that what most people can appreciate about public health throughout COVID is just how deeply mired good public health is in data, and that you let the data drive the decisions, and that you as a public health entity are responsible for collecting that data, measuring the outcomes, and providing regular updates. Because particularly in a pandemic, but honestly, even in day-to-day public health, there are many opinions about what's happening. There are lots of people's own internal perceptions about what might be happening. And there is a huge need for there to be a robust and reliable and believable source of data. And that is one of the several pillars of public health. And I think you ask, what are some of the challenges as you bring mental health into the fold? I think I would say 3 challenges. First, the fact that mental health for some reason has always been thought of as separate and aside from physical health. The fact that we even have to carve it back in is part of the problem, right? Like, where did it go and why did it go there? Why didn't it stay as part of the full holistic continuum? So that divide that we are now trying to compress back into a holistic sense is a problem, right? Not an insurmountable. Secondly, healthcare and health and wellness really relies on there being a global responsibility from all of the providers and treatment entities to say, this is something that we have a responsibility to deal with. So I'll take tobacco cessation, for instance. There's no one zone of healthcare that owns tobacco cessation. It could be your dentist that tells you that it's time to quit smoking and advises you to quit. It could be your orthopedic surgeon. It could be your OBGYN when you're going to pregnancy. So we have collectively said, this is our responsibility as healthcare practitioners and as the public health field to think about tobacco cessation. However, mental health has been very, very pigeonholed in certain areas, like to the psychiatrist, to these very specialized entities, without a global understanding that it is us, it is our communities, it is our churches, it is our schools that all play a collective responsibility in addressing mental health. So sort of bringing that back in and saying it is all of our responsibility. It's not just about therapists. It's not just about psychiatrists. It's about all of us, how we live, how we work, how we play. We need to think about these behavioral health issues. What are the impacts of social media and others on our children? And I would say the last piece is, and it relates back to my first point around the data, it is quite easy to measure whether or not you have COVID, or whether you have had a COVID shot, or what your A1C is with your diabetes, whether you have HIV or whether you don't. It is much harder to measure whether or not you have depression or anxiety, and is it getting better or is it getting worse? And I think that that's where the public health infrastructure that does normally such a great job with data has to work even harder to be able to amass the data sets necessary to share and shine the light on where the issues are. Is it that people are being underdiagnosed? Is it that people who are diagnosed are not getting into treatment? Is it that people who are in treatment are not staying in treatment long enough? Is it that the treatment, no matter how long you stay in treatment, is just not as effective as we'd like it to be? That's the public health cascade that we take and bring to bear on other disease issues. And it is truthfully harder to bring that public health cascade into the sphere of mental health, as well as to think about the roles of the non-clinical settings, which are so vital in public health, right? The places we live, the places that we pray, the places that we work. And so I would say, in a nutshell, to me, those are the major challenges that are, again, not insurmountable, but make it harder to bring mental health into public health where it belongs.
Perfect. And Jennifer, Amanda's talking, she's sort of speaking about, like, how do we get, granular definitions about these different diseases? How do we get solid, reliable data about these different diseases? How do we really make distinctions that allow us to, help people in very specific ways? Mental illness does not discriminate in who it affects, but the outcomes disproportionately impact marginalized groups and people of color. So, in your work, in the various organizations that you've worked with, how do you see, what Amanda is discussing, how do you see it sort of express itself through sort of a lens of discrimination, through a lens of race and ethnicity?
Ooh, that's a loaded question. And we could spend several hours here today talking about that. And frankly, there is a lot of talking that needs to be done there. There's a lot of talking, a lot of acknowledging, and a lot of reparative work needs to be done. I too want to thank Dr. Vasan and express my appreciation for being here and being with you, Amanda, and also with you. As we have this very important conversation. It's a very critically and, much needed, ever timely conversation. So I lead FPWA, which is a nearly 100-year-old social policy and advocacy organization. It has more than 200 member agencies, human service agencies, and faith-based partners that have long been doing traditional social services work. Working with families with low income who here in New York are, in the majority persons of color, working on child care, child welfare issues, youth services, services and supports for aging persons, people with health issues. And, not so much people with mental health are calling it out in that way. And what I'll tell you is that I'm reminded in this moment of Maya Angelou's words when she said, when you know better, you do better. And in recent years at FPWA, we've learned more and we're seeking to do better with all of the research that abounds, helping us appreciate the inextricable link between poverty and mental health, between incarceration and mental health, between adverse childhood experiences, ACEs, and mental health. And as you're pointing to, between systemic racism, structural racism, and trauma and mental health, we're seeking to do better. And the research and the data, unfortunately, in this society, just as Amanda was speaking to, it's like, if you can't document it, even if you can feel it, even if you can see it, if it can't be documented, then, how significant is the problem? What I'm grateful for is that there is more research and there is more data that's documenting the problem, which is a very first key, like a key step here in America, at least, for dealing with it. So, poverty in children and among adults, we are learning more and more can cause poor mental health through, stress, stigma, trauma. If you can't put food on the table, if you can't keep a roof over your head, that's a huge stressor. And that's going to lead to, significant, and common mental health disorders, mood swings, the inability to cope, withdrawal, depression. And when that happens, that leads to then, furthering the problem. Because if you're depressed, you don't want to get out of bed. You can't go to work. If you're a child and you're suffering from anxiety because of poverty and these stressors in your home, then, it's difficult to show up in school and, and listen and be a part in a way that helps you to grow and mature academically, educationally. We know that incarceration can trigger mental health or worsen symptoms of mental health. Here in America, we've got more than 500,000 people who are incarcerated and suffering with mental health. What we're told through the research and the data is that we've got 9 times more people in jails and prisons with diagnosed mental health challenges than in facilities where they could be better cared for. We know that if you're incarcerated, you can experience additional mental health. You can experience mental health stresses, like watching violence, living in solitary confinement, all have an impact on your ability to cope, to engage. And they cause mood swings, further disengagement. They can result in producing violent reactions because of those mood swings and the inability to cope. And so we know that, these are triggers too that aren't being addressed. They're not being dealt with. One other thing I want to share, and this gets to the heart of what you're saying. Structural and systemic racism for 400 plus years have resulted in interracial trauma, racialized trauma, and mental health mental health challenges that have resulted. Just think about it for a moment. If you watched, 300, 400 years ago, your ancestors, right? I shouldn't say your ancestors, your children, your partners, your parents being sold off and told that you could not show any emotion. And then bring it forward today. If you watch your brothers and your sisters, your mother, your father, your children being over surveilled, over arrested, over penalized for crimes that are happening and occurring, or things happening and occurring in other more white and affluent communities, and those people getting over, but your children, your parents, experiencing the worst of it, you're going to be traumatized. If you experience on a daily basis microaggressions, people coming at you, making you feel or wanting you to feel that you're less than, that you're not as good, you're not as capable, you're not as smart, that you are the reasons for your problems, you're the reason you and your family live in poverty, you're going to be traumatized. you're going to live, you and your family, your ancestors, and your children to come with trauma and some resultant mental health issues. So this is a huge problem that America, just as, it has not addressed, racism in other forms, is not addressing right now. What we need to do in this moment is appreciate, just as we're doing here, that unless we as a society deal with mental health, these issues, the stresses attendant with poverty, the stresses attendant with incarceration, adverse childhood experiences, justice involvement, right, racism, the problems are all just going to be exacerbated. And our mental health issues are just going to grow all the more. So the data and the research is there, and we see it every day. All you have to do is walk the streets of New York, and you're going to see it every day. And let me just add, go into the schools right now. Go into the schools. We're not even talking right now about the children, the many children who are suffering, who are traumatized because of COVID, and many Black and brown children who've lost significant numbers of family members. We don't really talk about that. They're traumatized. They're going to have a lifetime of mental health challenges.
Yeah, it's at times I feel like it can even feel so overwhelming. The problem is just so large, and it extends back through time at such a distance. Ashwin, before I toss it over to you, I want to remind folks who came late that you can submit some questions in our Q&A function. But so Ashwin, when you hear what Amanda has laid out and what Jennifer has laid out, I'm wondering what it brings to mind in terms of priorities. You began your career in public health. You've worked as an MD with low income and uninsured populations, and now you're running a mental health organization, Fountainhouse. What if you were president for the day, if you were mayor for the day, what are your priorities? What are your top 3 priorities that would need to be addressed right now in this moment that we're in with the pandemic?
Yeah. So I'm just still taking in a lot of what Jennifer and Amanda have both said, but I have to co-sign a lot of what they said, because what Amanda's raising are very, very real challenges within public health as it's currently conceived. And what Jennifer is raising is that not only are these issues inherently structural and intergenerational, they're inherently social. And we know this, right? The contribution of healthcare to health, by most estimates and most studies, is 15, 20%. The rest is behavior, genetics, society. And so what this raises to me in a zooming out lens is that public health needs to step it up, and that leaders, city, mayors, the president, whomever, executives need to resource it. Congress needs to resource it at a level commensurate with its importance in society. Public health has been, and Ed Young wrote a fantastic piece in The Atlantic about this just a few weeks ago, how public health has basically abdicated its responsibility on social and political advocacy. It's basically said, we're a science organization, we're a science field, and that's where our work ends. And so trust the science. And let's just be honest, how far has that gone for us in this pandemic? We're in a constant battle between science and society. Instead of saying, hey, as a field, we know what the science is, but we also know what social policy needs to be to disseminate the science, right? We can't leave it to other sectors to take ownership of those fields. Public health has to be a voice at the table at all of those discussions, if indeed the goal is to save lives. And in a pandemic, what else can the goal be? Save lives, return back to normal, rebuild economies. They're all connected. So we need a fundamental rethink at the role of public health in public administration at city, state, and national level. And this is not just to look into the future, but also to rebuild. 32 states have had additional restrictions placed on their public health departments during the pandemic. We've seen unprecedented turnover in the field because of direct targeting, violence against public health workers, threats to frontline workers. So this is a field in some ways under siege because of the political climate, and it's going to take, and the social climate, and it's going to take some new leadership and new framing for these issues to kind of give it the seat at the table that it rightly deserves. And that extends to public health, whether it's epidemic response or tackling the challenge of mental health at scale, bringing together a whole of society, whole of public administration approach to tackling issues that Jennifer rightly pointed out are inherently social. Right? There was a recent experiment out of Stockton, California about universal basic income. Whatever you think about the policy, it put money into people's pockets who needed it. And what did it measure? It measured a whole host of outcomes, one of them being self-reported depression and anxiety and function. Guess what? It worked, right? Lost days of work, self-reported symptoms, relationships in the home. These all improved when people had more economic security. Translate that to other social determinants of health, as we colloquially refer them to, right? Housing, criminal justice, criminal legal system, I should say, right? These are all factors that, yes, the levers of control of those sectors sit in other domains and in other agencies, let's say, if we're thinking at the city level, but where mayoral level leadership, executive level leadership has to drive coordination across them towards singular goals and to hold people accountable across agencies towards those singular goals. And mental health is just one of them, whether it's intervening in schools or addressing the crisis of serious mental illness in our city. Those are not goals that the Department of Health and Mental Hygiene can own on their own. They just don't have the levers. Those are not goals that the public hospital system, health and hospitals, can own on their own. They just don't have the scale, right? They can all make contributions, but where we need data and accountability and leadership is at the mayoral level to say, this is a priority for me, and I'm going to drive coordination between housing, criminal justice, schools, public health, hospitals. And that's a tough thing to do, right? Because any city executive or state executive isn't in control over all of that, right? Federal rules, federal funding, mental health parity, and the role of payers and how we pay for healthcare in this country. Those are not all in control of a city executive. But what they can do is at least identify the areas they can move the needle on, and then identify where they need to use their bully pulpit to put pressure on the state and the feds. So what I'm really advocating for is us to step back and situate these goals at the right level. Because if we just farm it out to particular agencies, we're going to end up throwing up our hands and saying, well, we didn't really move the needle on population health, but we built a lot of programs. We employed a lot of people, right? We have a lot of process outcomes. None of it is really materially changing people's lives in the short or the long term, and certainly not for our children in the next generation. So I'm really hopeful of new leadership that can start the process of creating a more muscular version of public health that is well situated and well coordinated within public administration, and not just an afterthought, not just you need it, you only know it when you need it kind of thing, which is how public health has been regarded since its inception for the most part. And so yeah, that's what I would like to come out of this. And that again applies to tackling population mental health, tackling population health for physical conditions. The last thing I'll say is that I think mental health actually offers us an opportunity. It's really hard to conceptualize for the average person how diabetes or cardiovascular disease or cancer is affected by all of these social determinants. But mental health is a lived experience, day to day. We wake up every morning, I'm feeling good, not feeling good. I have function, I've lost function, ready to go, not ready to go. It's a dynamic, it's not only a set of conditions and diagnoses, it's a dynamic lived experience in a way that, and it's universal in a way that diabetes or cancer and all of these things are not. And so it should be an opportunity for us to truly come around a population and public health agenda, because we can all appreciate it on some level. That's why I came into this work. I'm not a mental health expert. I didn't come with a broad base of expertise in taking care of patients with mental health issues, though I take care of a lot of them in my primary care practice still. But I came because I saw an opportunity to address a population health crisis, deaths of despair from suicide, alcoholism, liver disease from alcoholism, and complications have been rising for the last 20 years. Drug overdoses have been rising for the last 7 to 9 years with the opioid crisis. And then COVID hit on top of that and has exacerbated all of those things and worsened mental health for our children. If that's not a population and public health crisis, I don't know what is. Right? And so I came to this work, and I hope more people will come to this work who care about public health, because they see that this might actually be an opportunity for us to build a new kind of way of intervening at the intersection of science and society.
And then, I want to swing, that monarch for the day question back down the panel pendulum, the list of panelists here. Jennifer, if you're president for the day, you're mayor for the day, or you're the mayor for 8 years, what would be your 2 to 3 top priorities right now, within the scope of the work that you do?
Well, I think the
unlimited funds. You can do
I
anything
think the
you
first
want.
thing I'd have to do if I was mayor for the day is make sure that I had myself a very good therapist. And I say that both in jesting and in all sincerity, because it is a daunting job, and you need to check yourself and reset, check yourself, and have all the supports that you need. I believe that the first thing that we have to do as a city is recognize how pervasive is this problem. And in some ways, I feel that that COVID can help in doing that, because COVID has caused just about everybody, if not everybody, to experience bouts of angst turned anxiety, challenges getting up and getting out of bed and getting into the routine of the day, depression for many people. And so this is it seems a perfect time to say to all New Yorkers, this is something that we're living with and we're grappling with. And for some of us, it's presenting, more severely than others, but it's something we're all grappling with. As it concerns people, concerning people for whom mental health is an enduring challenge, and especially for lower income persons. I could not agree, could not echo more the thoughts and the sentiments expressed by Dr. Vassen. We need to ensure adequate coverage and funding for mental health supports. We also, as he spoke to, need to look at preventive measures. If we know so well, which we do, the correlations between poverty and mental health, between, as I've shared, justice involvement and mental health, racism and mental health, then we know what are, just as we know what more and more what are the social determinants of health. These are very often and very much the same social determinants of mental health. So let's look at how do we fund and adequately support services and programming that is multidimensional, You know, so often, and Dr. Vasan and I and several others several years ago did some work looking at how contracts for human services are funded only to address, you know, what appears to be the presenting issue. A family is in crisis. Let's give them preventive services. Maybe mom or dad has a substance problem. Let's address the substance abuse issue. Mom and dad, you know, are without jobs, or mom is without job, father's incarcerated. Let's give them a housing support, a child care support, as though that alone is going to address the issue. And we ignore, we minimize the mental health challenges that attend. And so developing a social services, human services, government contract schematic, where there's flexibility in contracts to get families and individuals who are challenged the supports that they need. I think we need to do more to build out trauma-informed care, to help practitioners, be they social workers, you know, case managers, working with people who have, you know, poverty-related stresses and justice involvement stresses, racism-related stresses. Develop a trauma-informed, a systemic trauma-informed care model where these practitioners can identify the signs of trauma and mental health, and then connect people to those resources. So I think too that it's a holistic approach, but we know what we need to do. We just need to be centering on these social determinants and develop a preventive as well as intervention approach.
Yeah, I love that. I love that idea of preventive measures for social determinants of mental health. You know, I think you know, my research background prior in my days before being a journalist, you know, involved Alzheimer's disease and stroke. You know, we know with a lot of these chronic neurological diseases that, you know, by the time there's a diagnosis, it might be too late. Like, we really need to be able to identify these things early on and start tackling them early on. You know, before I bring in some questions from the audience, because we have a few, and I want to remind folks that you can submit questions to the audience via our Q&A chat for those people who came in late. Amanda, same question. You know, you're the president, you're the mayor for the day. You have unlimited resources. You know, what do you tackle maybe in the data space or in the medical definition space? And I found it really interesting that you brought up data, because, you know, I'm looking at the city and state data all the time for stories, and it's unbelievable how the two systems often don't overlap, even in just how they code their individual data, the definitions that they have in their individual databases. But yeah, what do you think? What would you do first? What would be your initial priorities?
And I think, you know, not being a real data expert, I would take the answer to that question a slightly different way, to say, what is it that we need to measure? I don't know. I don't have the answer to how. But Jennifer Jones mentioned the Adverse childhood event. And we are learning so much about the role that early childhood plays longitudinally in both mental health and physical health. So children who have amassed adverse childhood events, be it that their parents were divorced, the loss of a parent, violence in the home, and others, the total amount of those negative hits translate years later in a higher risk of depression, that makes all the sense in the world, but also a higher risk of things like diabetes and other chronic diseases. Like, that profound understanding of how we really hard to fix something 20 years down the road is the sequela of something that happened well in the past. And I think a lot of what we try to do is fix the now, but we also have to get in, that whole, you can scoop people out of the river, but you should also figure out why people are being pushed in the river and stop that too. And you have to do both at once, right? You can't people who are in the water drown, but you also do have to stop putting more, people at risk. So I would say a profound focus on making sure that there's adequate measurement of the adverse childhood events, and also the concept of sort of families and the social structure that has really, if we're honest, I think really fallen apart. I saw a really funny meme the other day that said, I know it takes a village. I heard it takes a village to raise a child. Do they just show up, or is there like a specific number you have to call, right? And to me, I mean, it was both funny and sad, because I think that so much of what's happening, particularly in people with poverty, is the lack of connectivity to things like churches or groups or places that can offer the assistance in a way that helps the family. We take a very sort of standoffish, like, that's your kid, that's my kid, those are your problems, these are my problems. And there have been, I think, in the 20 years that I lived in this city, there's been a couple moments where we were able to, like, almost as a society raise above that. And one of them was right after 9/11. The horrible experience of 9/11 profoundly traumatized everyone so much that for a while, I felt like we lived in a little bit of a halo where people were just nicer to each other, more understanding of each other, more willing to say, hey, are you okay? And I think bringing back that humanity into our approach to families, our approach to children, is going to be a huge part of the prevention that Jennifer Jones so rightly highlighted. And so how do you translate that, like, very touchy-feely, like, motherhood and apple pie statement I just made in something that is direct policy? I would say one of the things that the prior administration under de Blasio, or I guess current now, I think really did get right was around 3PK and UPK, and recognizing that it's important for children to be in school for them, but also for parents who are trying so desperately to make ends meet. It's really hard to do that when you also have to provide, like, daycare. And to the points that were made before, you don't have this broad network available, accessible, other adults or care providers at your beck and call. So making sure that children have universal access to that schooling, I think, is paramount. And that also extended, frankly, through COVID. There was a huge push by parents to say, you have to keep the schools open. Like, regardless of what's happening with COVID, closing the schools is not the answer to this pandemic. And it was an incredibly unpopular, and there was, like, teachers, we all lived through the challenge that posed, but this understanding that families need to be able to rely on good social infrastructure, including schools that are open, that provide meals for kids that are hungry, that provide, to the point that was made before, caseworkers who can identify when children are just, like, not okay that day, and can check in and do team meetings with the child, with the parent, with the family, where we can offer different kinds of behavioral health support, social emotional supports in the schools where the children spend a lot of time. That, in some senses, like, relieves part of the burden on the parents for them to deal with the many, many other burdens that they have. There's no end to the parenting burdens, right? And so really to be able to say, what is the role that we as society can play in really making sure that children have, like, all the right access points to a healthy, nutritious, educational, safe, like, societally mixed and a good experience. And there are a lot of real good policies that underpin that, and investments that we make. I know that there's, a lot of debate right now at the Paid Child Leave Act and all these other things. We are grappling with this as a society right now, saying, what can we as a society pay for that promotes better early childhood development? And I think that is the piece that we don't talk about often enough. It does feel super squishy at times, and it feels like motherhood and apple pie, but that is not. There are many, many things that we can structurally do, some of which have already thankfully been done. But now you think back to universal pre-K. How did we not have that in the past? How is it not okay that we don't have that all across the United States? Why is that just like a relatively local phenomena? I think those are the kinds of things that, whether you're mayor for the day or governor for the day or president, we have to start really contending with what are those paid supports that we have to offer families so that we don't overly burden them and create problems that will take years to fully unravel, and then many, many more years of treatment to try to deal with.
Right, If
So
I may
that's
just
what I would
quickly,
say.
if I may just jump in here.
Of
Um,
course.
Unfortunately, I have another Zoom speaking engagement that I have to run to in about 8 minutes. I just want to jump in here, just say two things. Appreciating everything that Amanda said and Dr. Vasan as well. I don't think that we can let this conversation, this question about what to do as mayor, come to a close without acknowledging what this administration, the de Blasio administration, with the First Lady, Shalane McCray, leading the way, has done to raise our awareness as a city. And, for that matter, in many places across this country as a society, about the significance of mental health challenges in our communities, in our families. The Thrive Initiative, that she launched with Mayor de Blasio supporting it, and the administration has helped tremendously to reduce stigma, especially in communities of color. It is engaged, like community leaders, particularly faith leaders, who, have often shun away from conversations with their congregations about mental health. It has opened those doors. And so, we do have some tools that are already in the toolbox that we just need to pick up and build on. And then one last thing I want to say, because I've been reading the chats, and there's a very brave, in my opinion, individual who wrote about the historical 400 plus years of, like systemic racism and as this person put it, not dwelling on these issues, 400 years ago issues, because it's not mentally healthy. I appreciate this person's, being brave and being courageous, but I would implore that person to just do a little bit more homework, because these are not issues that happened just 400 years ago. These are issues that have persisted and still today persist. And there's a lot of research that has been done that speaks to how trauma is handed down generation after generation after generation. The body keeps score. The mind keeps score. And so, and there's a lot of research that also says that before you can deal with a problem, you have to acknowledge it. You have to acknowledge its root. So we're not just dredging up things that are of the past. They're very much alive and well today. We can't deal with mental health without addressing that and acknowledging it.
Dr. Vasan, do you want to comment quickly? I think I see your hand up. And
Yeah, I couldn't agree more with Jennifer's sentiments right now. Thrive is an example of the kind of executive level priority put on mental health that we need much more of, and we need to see mature into the next administration and well beyond. The fact that the biggest city in the country, one of the biggest cities in the world, centered mental health throughout an administration, made it a priority, that is a big deal. There's just been a lot of talk, a lot of criticism on whatever you think of execution. We can have that debate, but the fact that they did it, the fact that they put it near executive leadership, the fact that they're trying to instantiate it throughout city government is crucial. And we need to perpetuate it, improve it, grow it, and provide it with the kind of leadership and integration with the rest of the health infrastructure across our city. The reason I put my hand up, Sikan, was also because I realized I didn't answer your question, which is what would I do if I was mayor, right? Or president. And I think, well, let's just get real about some of the numbers, right? The fact that mental health has been siloed since time immemorial, it has led to chronic underinvestment in it. We spend $4 trillion on healthcare as a country. We spend about 6.5% on mental health. That's not commensurate with its impact. Mental health conditions, serious mental illness are amongst the highest cost drivers across age and demographic groups, from adulthood onto the Medicare population. It is the driver of disability and other chronic physical health conditions. And people with serious mental illness in particular, but not only, live up to 25 years less as a result of that cumulative toxic stress, cumulative medical and physical neglect, and cumulative effect of great social isolation and need. Isolation having been shown to be equivalent, persistent isolation being equivalent to smoking 15 cigarettes a day. So that's a public health crisis that requires a investment into solutions commensurate with its scale. There are 13 million people living with serious mental illness specifically across the country. There are 300,000 in New York City. 40% of those people are in no care at all, meaning completely shut off and isolated from most systems. That is a problem. And where are the solutions? We have a mental health system chronically underfunded where 1 out of 3 Americans lives in a mental health desert. That means 115 million people can't access care when they need it due to geography, lack of coverage, or carve out in their plans, name it. There's just a whole host, or lack of cultural competency, linguistic competency, social and demographic competency that makes the care inaccessible in other ways. So we've got a huge workforce gap, a huge access to care gap that is influenced by the way we pay for mental health care versus physical health care. The concept of parity needs to be enforced. We have good laws on the books that are not well enforced. We also need to really push, and the pandemic provided some good evidence on this, that into telehealth, telemental health, to expand access across states and to expand access into hard to reach communities. That can't be temporary flexibilities during the pandemic. That has to be a permanent part of our mental health workforce going forward. Number 3, we need to invest in peers and task shifting, which means we are not going to be able to train enough psychiatrists, psychologists, social workers in the next 5 to 10 years to fill that massive workforce gap. That's going to take a solid generation to fix. So what are we going to do in the meantime? Are we just going to accept these care gaps and lack of access? Or are we going to be creative and start to train people with lived experience, licensed behavioral health peers, mental health first aid disseminated throughout the community, and strengthen the role of primary care providers and other aspects of the public health workforce and healthcare workforce to provide mental health screening and care. That's got to be invested in. The city can do some of that. The state and the federal government have to step it up as well. Number 2 is housing. We have an affordable housing crisis, and the intersection of chronic mental illness and homelessness is clear. Up to 40% of the chronically homeless population have serious mental illness and substance use disorder. So creative programs like recapturing empty hotels, building a permanent supportive housing infrastructure, getting rid of Byzantine rules that result in every single night in New York City, hundreds of empty supportive housing beds because of the hurdles that people have to jump through just to get in them. We have to have an administration and a leadership that's willing to tackle that head on. And then the last is social infrastructure, something that we don't really talk about as a part of public administration. And it comes in many forms. Amanda rightfully mentioned the role of schools. Absolutely, school mental health has to be a pillar of rebuilding our mental health system. Similarly, what Fountainhouse does is social infrastructure for extremely isolated people with serious mental illness. We need to invest and scale that too. There are just not enough places and spaces where people can go to break the hallmark features of mental illness, whatever the severity, whatever the flavor, which is isolation. And isolation, as I said, sort of builds up and accumulates over time and gets more and more severe if left unaddressed. So we need to invest in that social infrastructure in a serious way. And we need to come up with creative models it's not going to be one size fits all. Every single, different demographic groups at different stages of isolation are going to need different ways to connect, but we're going to have to tackle that as a public health issue. Those are just 3 areas where I think any new administration can come in and say, you know what, I got a plan for some of this.
Perfect. And I think that's a great way to segue into some audience questions. I think I've had the privilege and honor to ask some questions to our very informed panel, and I would like everyone else to have that opportunity too. So I'm going to bring in our voice of God, Jessica, to maybe ask 2 to 3 to 4 audience questions.
Excellent, thank you. And just a reminder, if anyone has a question, please post your question in the Q&A fields. You can find the Q&A window at the bottom of your Zoom screen to submit your questions. So your first questions, what techniques are most effective in bridging the gaps between social services, healthcare, and community-based services? And are there any policy models or practices that could be systematically adopted to avert homelessness and incarceration?
That is one heck of a question. A great one. I'm just going to posit a couple thoughts on that. So some of the great practices, and actually Dr. Vasan alluded to them, is one, putting the right person in charge of the task. So often in medicine, we try to jam everything through the doctor, mistakenly believing that because somebody's got an MD or a DO or a PhD after their name, they must be the most capable person of handling the situation. And actually, research has shown us time and time again that that is not true for all things in healthcare. And that, for instance, the use of peer-based models, for everything from supporting people who have diabetes, who need assistance bringing their A1C under control, tobacco cessation, and substance abuse, like the KSAC counselors. These people are actually not just a source of a solution to the physician shortage, they're actually better than the physician in many, many, many cases to effectuate the change and engage the patients in their health and wellness journey. They can share real practical tips that perhaps providers like that are, physician licensed and others may not have as useful a set of like tips and tricks to share because they don't come from the same background. I think often, I hear overuse the analogy of like, referring people to like kale and other things that are just like culturally, like really not acceptable across a whole host of cultures, a host of ages. And I remember in my work at Montefiore, the social determinants of health, one of the things that was really, really important for me to come to understand was that if you are trying very hard to put food on the table for your family on a very limited budget, you are very risk averse to trying new things, because if the kids don't eat it, there is no other substitute, right? You have got to stretch that meal and you've got to provide the calories to your children that they will eat. You are not likely to try like riced cauliflower in lieu of regular rice for fear that your children actually won't eat it. And that is something that we have to like understand, that if you come from a different place when you're trying to make some of these health and wellness changes, but you're doing so in a setting of profound social determinants of health issues. So I think that's one important piece. Another model that has worked really well is team-based care, trauma-informed team-based care that leverages social workers who are generally quite well adept at navigating all the different social service agencies, aided by tools like NowPow and Unite Us and Healthify and Health Leads that form like these kind of directories that allow social workers to go beyond the like Rolodex that they might have accumulated over time, but to really be able to tap into even more resources than the ones they already know about. That is an evidence-based practice. And the trauma informed, I think I really can't put more of an underline on it than than Jennifer did so well. But the trauma informed care is coming from a place of like not what's wrong with you, but what has happened to you, right? And just that frame shift of how is the person that I see in front of me today, how have they been, how have they evolved from their experiences? And the more that I can understand that, the more that I can be an appropriate, empathetic person in this person's journey. And that comes even from little things like even the words we use, like substance use disorder versus drug addict, right? Those are completely different ways of describing an issue. One is just incredibly offensive, and the other says, I understand that this is a behavioral health condition that you are afflicted with, right? The other is like, you are a bad person making very bad choices. And if you could stop making those choices, you'd get better. And all of that in those two words, like load up that kind of like that message versus the others, like just using the words carefully to make sure that we understand where people come from. I think that those are some of the evidence-based practices. Obviously, so are all the treatments that are in place, like medication-assisted treatment. We don't ask people to just quit smoking cold turkey because that would be stupid, because it has like a less than 3% success rate. If we're doing our jobs as practitioners, we are offering people nicotine replacement therapy. We're offering them patches and gum, and we're acknowledging that it's going to take 8 to 12 weeks, and we're going to, we understand we're suggesting the right things. We don't just tell people stop smoking. Same thing with like opiate use disorder and alcohol disorder. We have to be promoting the evidence-based practices, the medication-assisted treatment in combination with therapy. And I think that those things need to be much more ubiquitously understood and organized, and make sure that primary care providers who are willing to screen for substance use disorder, alcohol, mental health issues, feel like they can do so and then be supported in the next steps. Maybe they're not so comfortable with treating those illnesses. Like, what is the team-based care model that allows them to do the initial screening and the identification, because they're in a good position to do that. And then also feel like they can, start with the first round treatments, try that. And if that doesn't work, like they can escalate. They don't have to feel like they're taking such a risk of screening. I say this because there are many, many providers who don't screen because they're afraid of the answer. They're afraid that, they themselves are not don't feel supported in providing the treatment that the patient needs. And it's like a little bit of like a don't ask, don't tell approach to it. And yet we know that there are many, many treatments. Many of them can be disseminated in the primary care setting. I would say, MetroPlus, we're a wholly owned subsidiary of Health and Hospitals. Health and Hospitals has an incredible dedicated effort, concerted effort at making medication-assisted treatment available, not just in their substance use treatment centers, but also across primary care. And they are making it a mission to make it available wherever. So you can go get your primary care, you can get your flu shot, you can get your COVID, and you can go get your medication-assisted treatment. You don't have to go someplace else, to go get that treatment if you don't want to. And I think that that's part of, making sure that there's a no wrong door. And we ended up doing that early on, in HIV at the beginning, you had to go to like HIV specialists. Now you can get your HIV treatment cared for at your primary care provider. You could choose to go to an HIV specialist. That's cool too. But you can also get it in a place that's like, that's a part of your holistic care. And we need to do the same thing for behavioral health without forcing people in one place or the other. It should be a no wrong door. You raise your hand, you could be at the orthopedic surgeon and you could say, I am suffering from depression. We should have workflows to get you to the right care. We've done it with many other disease areas. It's time to do this for behavioral health as well.
Anything to add, Ashwin?
No, I mean, I think that just briefly, I think what Amanda's highlighting is that there's very little in the way of consensus in mental health and behavioral health. And that's part of the problem. There are no, when Obamacare came online, what people ignore is that it was also incorporating the previous 10 years of work, 10 plus years of work on establishing quality standards and standardization of primary care, my field, which was 20, 30 years ago as unstructured and decentralized and confusing as mental health care is today, behavioral health care is today. So we need a similar frankly, national quality framework for mental health, where we can get stakeholders together and establish some agreed upon models of care. If we don't have them tested and we don't have the evidence base, let's go identify and research them and evaluate them. But we need a concerted effort to establish a roadmap for what community mental health systems look like, what does good look like, what does the evidence base look like. That's going to drive investment. It's going to drive consolidation in the field. It's going to get rid of some of this Wild West kind of feeling in mental health, which I think for any of you who've even just tried to go to a therapist, it's the Wild West for sure. And so we need some concurrent federal leadership here. States can only do so much, plans can only do so much, provider systems can only do so much in the absence of some agreed upon standardization. And so I'd like to see us put some real effort into that. That's something that Fountainhouse is really starting to pay attention to. I also think that we just talked a lot about how social need, social drivers, social determinants are highly attributable in their impact on mental health. So the solutions are not going to lie in healthcare, in the dominance. And yet we get very seduced by the fact that we spend $4 trillion as if that $4 trillion is there for us to redirect in some ways. It's a seductive argument, hasn't proven to be true. We haven't found truly scalable, sustainable models of healthcare paying for social needs to move the needle on population health goals and epidemiologic goals. We have some nice pilots and things like that, but frankly, the way that we pay for healthcare is so constrained that expecting it to unconstrain itself to start tackling all these complex social needs, many of which Amanda raised, is unrealistic in the near term. I truly believe it's unrealistic. And so, okay, well then if you're not going to expect healthcare revenue to pay for this, or if it's only one tranche of money to pay for this, and it truly is, then how do we create a whole of government approach where we are bringing in housing revenue and we are diverting criminal justice revenue away from jails and prisons, and we're bringing in school revenue to focus in on mental health, and we're creating some joint funding to tackle population health goals. It's not been done before a lot, frankly, because once budgets are out into their particular silos and committees, it's hard to bring them back in. But you just need to look at places like Hennepin County, Minnesota, where they do global budgeting. They do administrative county level budgeting across systems towards whatever their system level goals are. And they're able to braid that funding, put it together, integrate it, fancy word of saying that, in ways that can tackle public administration goals, public health goals, and they've had some success. And so we need to be thinking about ways to truly invest in these public health issues using revenue from a whole host of sectors, because healthcare is not our savior here. It's just not going to save us. And yeah, that's what I would say.
Perfect. Okay, next question, Jessica.
Thank you. And do you think any additional positions or changes to the administration needs to be implemented to accomplish everything that you've outlined?
I think that the city needs something akin to like a chief health officer, something that sits above the agencies and has real accountability and real oversight and some budgetary control and influence. Maybe it's the deputy mayor of health alone or something like that. But whatever it is, we need to try to establish some citywide health priorities at the mayoral level that have real accountability attached to them. And I will say, we tried it before. We had Take Care New York. And we tried through a very tight partnership between health and hospitals, the health department, and the mayor's office to establish some citywide goals, some outcomes. The one criticism I would have is that it was just a lot. It was like way too many, and way too many for anyone to focus on. So let's pick 2, and mental health should be one of them. Let's pick 3: maternal health, mental health, pandemic preparedness. I don't know, but we need to pick some goals, public health goals, that we can marshal the resources of the government behind. And that's going to require someone who's endowed with real power at the mayoral level. It might be the mayor himself, but someone has to actually be able to move the needle here. Otherwise, we're just going to be sort of fighting the same fights and collaborating on the back end, which is really hard to do. I think we know this.
And I'm going to try to squeeze in one more audience question. I think this might be our final audience question. So go ahead, Jessica.
Thank you. How do we make sure that collecting data doesn't become more important than helping the actual individuals?
Great question. You have to do both. And even just to hold yourself accountable for making sure that what you're doing is actually working, right? I think there's what we want to make sure we put forward are, it's important to have a focus on mental illness for sure. It's important to have structured programs, but it's also important to step back and critically say what worked and what didn't. In everything, there are things that do work as planned and things that go completely awry when you actually, go to ground with them. Some of that might be that they were not implemented the way that they were supposed to, or some of them, frankly, when truly implemented, they still don't work. And it's important to hold ourselves to accountable for making sure that that we're doing things that work, learning about new things that could work, that could help us. So you can't just keep doing the same old and saying this is our bag of tricks and it shall never change. So I think that the question is a good one. How do you make sure that you don't overvalue one versus the other? Is that you don't spend 15 years trying to come up with what the metrics are, and trying to measure every single thing. You just come up with, I love the HIV public health cascade, right? It's how many people have HIV, how many people know that they have it, how many people are in treatment, and how many have viral load suppression. It's 4 kind of pretty easy things that are measurable. And there's many, many other things that you can measure in HIV and many things that are important for some other populations to measure with respect to that. But globally, if we can just step back and say at a high level, are we getting people, do people know their status once they're diagnosed? Are we getting them to treatment, and are they staying in treatment long enough for us to achieve the ultimate outcome? And I think just simplifying the metrics and really slapping our fingers back when we try to say and this, and let's cut it by this and let's cut it by this. But importantly, allowing for some of the important cuts of the data that have been that we shouldn't say are too complicated, like looking at the data by race and ethnicity. We will never be able to say we're making a dent in reducing disparities if we don't measure disparities. At the same time, so I would say that is an important slicer of the data to say that must be baked in. But then you also have to say, and therefore other things that would be nice to measure are not going to be measured, because the things that we must measure need to be done. So keeping it simple, adding the slicers that really are going to be keep us morally on track, ethically on track, and then saying some senses simple can be good enough in many, many situations, because it allows us to move the needle as a whole and measure progress. The challenge, I think, is if everybody comes to that measurement table and say, I want to measure it completely differently this time, or I want to measure something else, then we're not able to see things over time, which is a problem when you're trying to deal with issues that take years to fix, right? And so, it's not, anyway, I think I've hit the main points, but I think that those would be some of the things that I would focus on in order to make sure that the collection of the data doesn't dwarf or take away from what we're trying to achieve.
Ashwin, same question. How do you collect data without losing sight of the humans behind the numbers?
Yeah, and I think this is where my earlier comments kind of become essential. Public health has a tricky balance to navigate, which is you want to be a trusted and credible collector and disseminator of data. You want to be a trusted source that's unassailable. And unassailable over time, as Amanda rightfully said. We need to be looking at trends. I'm a big believer that we need to orient around public health and population health goals as a city or whatever construct. I've said that several times. So that only works if you've got an agency that is, I wouldn't say insulated, but certainly viewed as credible. But if their only role is collecting that data, or if they're not the agents of that data, or if they're not empowered to use that data to build things, lead things, divert resources, grow resources in ways that are truly influential, and if instead we continually undermine it, then, which we've done with public health across the country, then it becomes much easier to do exactly what the questioner asked, which is to have this data out there, but to not really be doing anything about it. And I mean, you only have to look at something like maternal mortality to bring that to light. We've been talking about the disparities in maternal health outcomes for more than a decade now, right? And who's actually moving the needle on it? New York City has made some progress in pockets, certain provider systems, but who's actually moving the needle on those things? Is the experience of the average Black woman giving birth in New York City markedly different, better, more reliable, less risky? I can't answer that with any conviction right now. So I think we have to challenge ourselves to use that data in ways that are influential, politically influential in policy, and commensurate with the scale of the challenge. Otherwise, anything we're saying on health equity or these priorities is just lip service, because you're not actually in the business of saving lives, which is what reducing something like the maternal mortality gap is about. It's about saving lives. No one should be giving birth and dying or experiencing complications from preventable poor quality care that has as its underlying root racism, right? Like that just, I think if you can't accept that to be truth, then what are we doing? We're just using this data to have a performative exercise in what we care about. And so I think public health has been relegated to data as performance at times, and we need to back it up. We need to really back it up with a public health infrastructure that's meaningful, that's well-resourced, and that can act on that data. Here's one example. I mean, we're starting to see certain pilot projects, and certainly the federal government's public health workforce initiative is encouraging. We need a permanent community-based public health workforce comprised of community health workers and peers, and those are the people that will be there all the time, engaging you on tobacco cessation and diet changes, and reaching out to you when you're pregnant and getting you connected into care, and can be activated during times of crisis, like epidemics. And so we don't have that currently. When COVID hit, I got these letters in the mail too. Come, Medical Reserve Corps, volunteer. Like, we have this sort of transient relationship with what's actually needed to respond to crises instead of building a permanent workforce. And it's a jobs program as well, right? So we should feel good about this. We're putting people to work, training them and putting them to work in our communities, doing what they're best suited to do, which is reach out to their neighbors, rather than people parachuting into communities that don't have the same lived experience and expecting them to magically form trust. And so I would like to see us really invest in a public health workforce that can address issues of mental health, of physical health, chronic illness on a regular basis, and then be ready for epidemic preparedness, crisis response, disaster response, whatever is needed in the moment. But if it's not there when you don't need it, it's not, why would we expect it to be there when we do?
Yeah, I mean, I think that's a really great place to leave it. You know, I think we are in this moment right now of tremendous change, and change is really just another word for opportunity. You know, I want to thank the Fountainhouse and Trinity Church for this opportunity to host this panel. I think it was tremendously fascinating, and also has sparked, I would say, about a dozen ideas for stories for us to pursue. Yeah, thank you. And, you know, I want to let the audience know that I'm sorry that we weren't able to get to all of your questions. You know, I see you in here in this chat talking about we need more community oversight. I see the language barrier questions, and those are also topics that fascinate me too. I'm sorry that we couldn't get to those. I'm going to toss it over to Ashwin. I know that a recording of this session will be available on the Fountainhouse website and also their YouTube in the Mental Health in Transition series page. Ashwin, yeah, take it away.
I just thought this was wonderful. Obviously, I certainly could keep talking for a while on this subject. It's one that is near and dear to me, and same for Amanda and Jennifer. So I want to thank them, first of all, for being here and for this wonderful discussion. I truly believe that we do have an opportunity to finally address mental health as the public health crisis that it is, by bringing the best of public health and public policy to bear on it. And so I'm grateful to have people like this in the space who think similarly and care deeply about these issues. Thank you to Sikon. Thank you, Sikon, for the great questions, the great moderation, and for facilitating such a lively panel. Thank you to the audience for your great questions. Again, apologies that we didn't get to all of them, but we're recording them and we can always follow up with you, and you'll have our emails. There's a lot of work to do, and we're all in this together. This is certainly not, you know, public health is both an issue of public administration and an issue of community organizing and community engagement. And we didn't even really touch upon that piece of the work in depth. And so we're all in this, and it's going to require all of us pulling in the same direction. So I'm eager to have that discussion and to do that work with all of you. Just as a note, recordings of all three of our sessions, mental health and transition panels, are going to be available at fountainhouse.org/MHIT. And that's it. I'll wish you well. Have a great rest of the day and a great rest of the week, and stay healthy.
Thank you.